Have you ever considered that the ultimate anti-aging or, healing serum isn't something being cooked up in some billion-dollar pharmaceutical lab? Like, it's actually coursing through your own veins right now.
Yeah, it's a wild thought. We are so conditioned to just look for external fixes, right? Whenever something goes
Like,
wrong.
exactly. Like a pill or some synthetic cream.
Right, or a surgical intervention. But I mean, the idea that our own blood holds these precise biological blueprints for complex tissue repair, it forces this complete shift in how we even approach medicine. It sounds a bit like science fiction, honestly.
It really does.
Right.
But it is grounded in, well, very real cellular biology. And that is exactly what we're getting into today. Welcome to today's deep dive. Our mission today is to unpack this fascinating, sometimes really controversial, and just rapidly evolving frontier in medicine, which is platelet-rich plasma, or PRP.
Specifically in the realm of gynecology, which is a whole other ballgame.
Right. We've gathered this massive stack of sources for you. We're talking clinical trials, highly detailed anatomical reviews, medical protocols. And the goal is to just sift through all of this and separate the marketing hype, like you've probably seen ads for the O-shot, from the actual regenerative biology.
Because there's a lot of hype.
So much hype. We want to figure out exactly what happens on a cellular level when you take, concentrated components of your own blood and inject them into the body's most sensitive tissues.
And, to put this into perspective, PRP itself is not this brand new radical concept. I mean, orthopedic surgeons and dentists have relied on this exact same biology for, gosh, over 2 decades now.
Wow, 2 decades. I didn't realize it was that long.
Yeah, absolutely. They use it to speed up the healing of torn tendons or to repair joints, even integrating bone grafts. But taking that established science and applying it to gynecological health, like using it to treat sexual dysfunction or stress urinary incontinence, that is a completely different frontier.
Because the tissue is just so different.
Exactly. It's literally forcing clinicians to re-examine human female anatomy and these incredibly complex neural networks that are involved there.
Okay, so before we get into that complex anatomy and like where this treatment actually goes, we really need to understand what this material even is and how it's made. Because you can't just draw blood, put it in a syringe, and inject it back into the body expecting a miracle.
No, it definitely doesn't work that way.
Right. So you walk into a clinic and they draw your blood. And the sources note this can be anywhere from 15 to 120 milliliters, which, I mean, that is a massive range.
It really is. It depends entirely on the specific protocol that clinic is using.
Right. So they take that blood, and then it goes into a centrifuge. And reading through this, I kept picturing a centrifuge as like a highly calibrated cellular salad spinner.
That's actually a pretty great way to think about it.
Yeah.
Basically, the centrifuge spins the vials of blood at these intensely high, very specific speeds. And because the different components of your blood have totally different physical densities, that centrifugal force separates them out. Into layers, right?
Exactly, into 3 distinct layers.
Oh, wow.
So at the very bottom of the tube, you get the heavy red blood cells. Then at the very top, you get the platelet-poor plasma, which is mostly just the clear liquid part of the blood.
Okay.
But sandwiched right in the middle, you get this really thin, turbid layer. It's kind of cloudy and opaque compared to the clear liquid above it. And that is what we call the buffy coat.
The Buffy coat. I have to say, it sounds like a heavy winter jacket or something.
I know, it's a funny name. But this cloudy middle layer is where all the actual biological tools are isolated.
So what exactly is in that cloudy layer?
So that buffy coat contains concentrated white blood cells and, crucially, the platelets. And usually, when we think of platelets, we just think of those tiny blood cells that rush to a paper cut to form a scab.
Yeah, just plugging a leak, basically.
Right, but they do so much more than that. Platelets are packed with these microscopic structures called alpha granules, and these act as like storage vaults for incredibly powerful regenerative proteins.
Yeah. By isolating the Buffy coat through this spinning process, clinicians extract a serum that has a 5 to 10-fold higher concentration of these growth factors than you'd find in normal whole blood.
But, and this is a really important distinction the sources made, the platelets in that vial are currently dormant, right? Like, if a clinician just takes that buffy coat and injects it, the platelets might just kind of float around aimlessly.
Yeah, they wouldn't do much. They need a signal. They need a reason to release that payload. So there is this chemical activation step that has to happen first.
And how do we do that?
Well, clinicians add a very precise amount of calcium chloride to the extracted PRP. Usually it's at a ratio of about 1 to 10. And this chemical addition basically mimics physiological clotting.
So it's tricking the blood.
Exactly. It tricks the concentrated platelets into believing they are at the site of a major traumatic physical injury. This sets off what we call the thrombin cascade. It's this chemical domino effect that forces the platelets to rapidly degranulate.
Degranulate, meaning they...
Meaning they physically burst open. They burst open and release all those stored growth factors from their alpha granules directly into the serum.
Okay, and those growth factors, they have all these alphabet soup names in the literature, right? Like PDGF, VEGF, TGF-beta. But looking at how they actually function, they act like a biological 911 text message.
Yes, that's a perfect analogy.
Once they're released, they send out this emergency broadcast to your body's stem cells, basically yelling, we need a repair crew down here immediately.
And that 911 text initiates a highly orchestrated response because the scaffold created by these proteins doesn't just calm down local inflammation, it actively promotes neovascularization.
Which is building new blood vessels, right?
Exactly. The literal creation and growth of brand new blood vessels right there in the tissue. And alongside that, the growth factors stimulate the synthesis of new collagen and hyaluronic acid.
So you're physically changing the tissue.
You are. You're physically thickening the local tissues, you're dramatically increasing hydration, and you're restoring blood flow to cellular networks that might have, degraded or thinned out over time from aging or trauma.
Okay, so now we have this activated liquid gold repair crew ready to go. The next step is deploying it. And this is where the sources dive deep into female sexual anatomy, focusing specifically on an area called the frenular delta.
Oh, the frenular delta is just an absolute anatomical marvel. The sources really highlight it as the primary epicenter of clitoral erogenous sensation.
Where exactly is it?
So it's this V-shaped or sometimes inverted Y-shaped area located on the ventral or the underside of the prepuce, right where it retracts.
Okay. And the reason it's the epicenter is all about the biological wiring, right?
Yes, exactly. It features this incredible anatomical overlap of neural pathways. You have branches of the perineal nerve physically converging with the ventrolateral branches of the dorsal nerve.
Just a massive intersection of nerves.
A massive intersection. And packed tightly within this highly innervated tissue are these enigmatic mechanosensory receptors called genital corpuscles. The density of nerve bundles and free nerve endings in this specific delta is staggering. And they are all specifically designed for the perception and transmission of sexual pleasure.
So keeping that highly sensitive, densely packed wiring in mind, let's walk through the actual procedure for the injection, which is commonly known as the O-shot, because nobody's letting a needle anywhere near the frenular delta without serious numbing.
Oh, definitely not.
The protocol calls for this potent topical numbing cream known as BLT, which, not a sandwich, it stands for benzocaine, lidocaine, and tetracaine. So the clinician applies that cream along with ice to just thoroughly numb the clitoris and the surrounding vaginal area.
Right. And once it's numb, the injection targets are dictated entirely by that underlying neural and vascular anatomy we just talked about.
So where does it go?
The standard protocol involves taking about 4 milliliters of the activated PRP and injecting it into the anterior vaginal wall. The clinician is specifically targeting the space between the urethra and the vagina distally, near the periurethral glands.
Which is often called the O-spot space in the literature.
Exactly. And then following that, about 1 milliliter of the PRP is injected directly into the clitoris itself, specifically targeting the corpus cavernosum near the glands.
Wait, hold on. I have a question about this. If the anatomy dictates the injection, how does a clinician adjust this preparation volume for patients presenting with entirely different physical issues?
What do you mean?
Well, for example, the sources talk about focal clitoral phimosis, right? Where adhesions actually trap the clitoral glands under the prepuce.
Right.
That is a highly localized, tiny area, but you compare that to a patient dealing with generalized anterior vaginal wall thinning. You obviously can't pump 5 milliliters of fluid into a tiny trapped clitoris, so how do they calibrate that?
That is a great point. The volumes are strictly tailored to the physical dimensions of the anatomical target. That's why that breakdown between the 1 milliliter and 4 milliliters is so important.
Okay.
Right? So for a focal, highly concentrated issue like clitoral phimosis, the adhesions have severely impaired both sensitivity and mobility. You only need, and frankly, you only have space for, that 1 milliliter injection.
Because it's such a small, dense area.
Exactly. The goal there is to deliver a very concentrated burst of growth factors directly into that dense gland to stimulate local nerve repair and essentially break down the restrictive tissue.
And then for the vaginal wall thinning, you're dealing with a vastly larger surface area.
Right. You're dealing with a wide expanse of mucosa and underlying connective tissue. That requires the larger 4 to 5 milliliter volume to create a broad biological scaffold.
You just need more material.
Yeah, you need enough volume to spread those growth factors out so they can recruit stem cells across the entire compromised structural wall rather than just one concentrated spot.
Okay, that makes perfect sense.
Right.
But hold on, time out. Let's talk about the actual name of this procedure. Because we see the O-shot marketed everywhere, usually with a registered trademark symbol right next to it.
Yes, you do.
You just walk through a process that involves drawing a patient's own blood, spinning it to isolate natural proteins, and putting it back into their body. You can't patent biology.
No, you can't.
So how is a clinician able to trademark a procedure that uses a person's own blood? Like, what exactly are patients paying for here?
It is a perfect example of the intersection between human biology and commercial medicine. Because you're right, you cannot patent human blood. You can't patent the biological process of platelets healing tissue.
Right.
What is patented and trademarked is the specific standardized protocol and the brand name O-shot.
So they own the recipe, basically.
Sort of. The trademark dictates the specific FDA-approved centrifuge systems a clinic must use, the exact injection sites, and the proprietary training a provider has to undergo to legally use that commercial label in their marketing. So the biology is universal, but the trademark is a way to standardize and monetize a specific delivery method.
That is so interesting. But regardless of the trademark, the clinical outcomes being recorded are striking. The sources reference the Runel's pilot study, which tracked patient outcomes using the Female Sexual Function Index, or FSFI.
Right, the FSFI.
And the study showed a mean increase of 5.5 points on that index. In practical terms, that translates to highly significant measurable improvements in a patient's arousal, natural lubrication, and their ability to achieve orgasm.
Which is huge for quality of life. But we have to look at the mechanisms driving those results, too, because sexual enhancement is actually only one application of this biology.
What else is it used for?
Well, the underlying process of neovascularization, that ability to physically build new blood vessels and synthesize fresh collagen, it's currently being deployed to treat structural failures and truly debilitating medical conditions.
Right, like that structural thickening we just talked about for the anterior wall.
Yeah.
That is the exact mechanism that addresses the next major application in our sources, which is stress urinary incontinence, or SUI.
Yes, SUI.
This is the involuntary leakage of urine when a person coughs, sneezes, or exercises.
Yeah.
And the injection protocol shifts entirely for this, right? Clinicians bypass the clitoris and inject a much larger volume, usually 5 to 6 milliliters of activated PRP, specifically into the periurethral area.
The logic for SUI is purely structural architecture. By delivering a large, concentrated volume of PRP directly around the mid-urethra, those growth factors stimulate massive collagen synthesis.
So it's building up the tissue around it.
Exactly. It's building up the ligaments and pelvic floor muscles supporting the urethra. The treatment physically rebuilds and strengthens the pelvic floor architecture from the inside out. It provides the mechanical support that the urethra is lacking, which is what alleviates the incontinence.
That's amazing. And this regenerative capability also extends to genitourinary syndrome of menopause, or GSM, as well as severe autoimmune conditions like lichen sclerosis.
Right.
Because in those conditions, the local tissues don't just lose structural support, they become incredibly thin, chronically inflamed, and severely painful.
And this introduces another crucial function of platelets, which is immunomodulation.
Immunomodulation. What does that mean in this context?
It means it is not just about building new tissue, it is about fundamentally altering the local immune response. When platelets degranulate, they also release cytokines.
Okay.
And cytokines are specialized biological messengers that regulate the immune system. They actively suppress and reduce chronic local inflammation.
Oh, wow. So they're telling the body to stop attacking itself.
Essentially, yes. In a condition like lichen sclerosis, which causes severe, disfiguring scarring and structural damage to the vulva, PRP helps restore the integrity of the dermal layers. Meanwhile, the cytokines alleviate the intense burning and pain that these patients just suffer from daily.
That brings us to maybe the most profound medical application detailed in the sources. It takes this tissue repair to its absolute limit, which is using PRP and reconstructive surgery for victims of female genital mutilation, or FGM.
Yeah, this is incredibly powerful. In FGM reconstructive surgeries, clinicians face profound anatomical trauma and deep, deep scar tissue.
So how does PRP factor into that?
The surgical protocol involves first removing the restrictive scar tissue and then injecting PRP directly into the remaining clitoral stump. The goal is to aggressively stimulate any remaining stem cells in the region and force new blood flow to the dorsal neurovascular bundle.
And the clinical results cited for these reconstructive patients are staggering. Some studies show up to a 90% improvement in sexual desire, arousal, and pain reduction following these autologous PRP treatments.
90% is just an incredible figure.
It is. And the sources note that these physical, structural improvements go hand in hand with massive psychological benefits. Using a treatment derived from the patient's own body to heal profound trauma plays this huge role in helping survivors psychologically reclaim their bodies.
It really demonstrates the absolute peak potential of these autologous treatments. When you remove the barriers of scar tissue and you provide a concentrated biological signal, the body's capacity to regenerate its most complex sensory networks is just remarkable.
So, hearing all of this, the obvious question is, if this treatment can accomplish all of this, if it can cure stress incontinence, reverse the thinning of autoimmune disorders, restore sensation after trauma, why isn't this the gold standard in every single gynecologist's office around the world right now?
Well, that requires a very grounded reality check of the current medical literature because the clinical data available right now is incredibly messy.
And messy how?
While orthopedic PRP has, decades of standardized research behind it, gynecological PRP is still really in its infancy, and the research reflects that growing pain.
Yeah, one of our sources highlighted a systematic review of vaginal relaxation syndrome that perfectly illustrates this problem. The reviewers looked at 74 different clinical studies on the topic.
74 studies is a lot.
It is. But across those 74 studies, the various researchers used 85 different measurement instruments to track their outcomes.
Oh, wow.
Right. And the vast majority of those studies had follow-up periods of less than 6 months. You simply cannot build a global medical consensus or write standardized care guidelines when the data is that scattered and short-term.
And the inconsistency isn't just in how they measure the results, it is in how the actual biological serum is prepared in the first place.
Yeah.
There is a glaring lack of a uniform protocol across the medical field.
Thinking back to our salad spinner analogy, how fast and how long you spin that blood changes the final product entirely, doesn't it?
Absolutely. The sources point out that some clinical studies used a single spin method at 1200 RPM. Other studies used a double spin method, maxing out at 3400 RPM.
That's a huge difference in force.
It is. And some protocols draw 15 milliliters of blood, while others draw 120 milliliters.
Which means the concentration of platelets would be wildly different.
Exactly. And, there's just a ton of confusion in the published literature between PRP, PRF, which stands for platelet-rich fibrin, and IPRF.
Wait, what is the difference between PRP and PRF?
So classic PRP uses anticoagulants in the tube to keep the blood in a liquid state during the spinning and the injection process.
Okay, so it stays liquid.
Right. PRF, on the other hand, does not use any anticoagulants, which allows it to form this dense physical fibrin matrix. Because of this structural difference, they have entirely different release dynamics and timelines for the growth factors.
Oh, I see.
So if one clinical trial is using a dense PRF matrix and calling it PRP, and another trial is using a low-spin liquid PRP, comparing their clinical outcomes is basically impossible.
It's like trying to judge a baking competition, but half the contestants used a blender and the other half used a microwave. The inputs and the processes are fundamentally different.
That is a perfect way to put it.
So what does this lack of standardization mean for the patient sitting in the clinic today? Because standard medical guidelines still consider the systematic evidence for gynecological PRP to be moderate to weak.
Yeah, they do.
Yet patients are actively choosing to pay hundreds, sometimes thousands of dollars out of pocket for these treatments, especially since they are rarely, if ever, covered by medical insurance. Why are they doing that?
It ultimately comes down to the undeniable promise of the biological signal and, frankly, a desperate need for medical alternatives.
Alternatives to what?
Well, take genitourinary syndrome of menopause, for example.
Yep.
Low-dose local vaginal estrogen has a massive, heavily researched foundation in medical guidelines. It is the undisputed gold standard for treating vaginal atrophy.
Right. Estrogen cream.
But not every patient can safely take estrogen, or wants to. Breast cancer survivors with hormone receptor-positive cancers are frequently advised against using any hormonal therapies whatsoever.
Oh, right. So for a breast cancer survivor suffering from severe atrophy, standard medicine basically tells them they are out of options.
Exactly. And for them, PRP represents a natural, non-hormonal, non-surgical lifeline. Even if the global medical community hasn't agreed on the exact recipe or centrifuge speed yet, the fundamental mechanism is biologically sound.
The platelets still do what platelets do.
Yes. Using your own concentrated platelets to signal tissue repair is a proven science, and it offers highly promising localized results for patients who have basically been left behind by standard pharmaceutical guidelines.
So it is a wild west of data,
Yeah.
but it's a wild west built on genuine, reproducible scientific merit. We've covered a massive amount of ground in this deep dive. We started with just a standard blood draw, spun it down to isolate the buffy coat, activated the body's own biological repair crew, and then followed that liquid gold as it was deployed into the incredibly complex neural network of the frenular delta.
We really went from the cellular level up to the whole anatomical structure.
We did. And we've explored how the clinical approach shifts entirely based on the anatomy. From those tiny 1 milliliter targeted shots to break down clitoral adhesions, to the large 5 milliliter doses designed to rebuild the muscular support of the urethra.
And of course, we've seen the very real, practical challenges of standardizing this frontier, highlighting the urgent need for uniform protocols so this biology can be reliably evaluated and accessed by the patients who need it most.
It definitely leaves you with something profound to think about long after this deep dive ends. If your own blood already contains the precise blueprints, the exact cellular text messages, and the physical tools required to regenerate your body's most complex and sensitive tissues.
It makes you wonder.
It does. Are we finally approaching an era of medicine where we stopped looking outward for pharmaceutical cures? Perhaps the future of healing isn't a new drug at all. It might simply be learning how to give our own bodies the precise command to heal themselves.
It is a total paradigm shift in how we view human biology and recovery. I mean, it changes everything.
It really does. Well, thank you for joining us on this deep dive into the regenerative power of PRP. Keep questioning the science, keep exploring your own biology, and we'll see you next time as we continue to unpack the incredible machinery of the human body.